Welcome to the live webinar with Dr. Dan Atkins. Dr. Atkins will be discussing approaches to the dietary management of EoE, and this is part of APFED's educational webinar series, and we're really happy that you're here with us this afternoon.
Thank everyone for coming to the webinar this afternoon, and I hope we answer a number of questions and have time to talk about a lot of questions. Our topic this afternoon is approaches to the dietary management of eosinophilic esophagitis. And this first slide is just to let you know that I have nothing to disclose financially that might affect the content of this presentation. But we're going to talk about eosinophilic esophagitis, so I thought it'd be helpful just to start with a few of the basics. Eosinophilic esophagitis is a clinical pathological disorder. So what that means is there's a clinical aspect where patients have symptoms, and the symptoms are those of esophageal dysfunction, or your esophagus doesn't work right. And when we look at the symptoms patients complain of, there's a difference starting from infancy to adulthood, kind of a transition of symptoms. So we see infants that vomit or they cough and choke when they eat. As they get older, they have feeding aversion. There are certain foods they won't eat. There are certain foods they don't tolerate. And then because of their difficulty in being fed, they have failure to thrive. They don't grow well. And as they get older, these children tell us that they have epigastric pain, which is, again, pain right below the rib cage in the center of the chest, or they have chest pain. And then they start to tell us that they have difficulty swallowing, that food sticks in their throat. And then some of them go on to have food impaction, where food actually sticks in the throat. They can't get it up and down, and sometimes they have to go in and have it removed through endoscopy. So those are the symptoms that patients complain about. And if we look at the esophagus, through an endoscope, you see characteristic findings. Some are represented in this particular slide. You can see the esophageal rings here. That's called trachealization of the esophagus because it looks a little bit like a trachea looks with these rings at times. And you can also see these little pustules, eosinophil or esophageal papules or pustules, if you will. And if you biopsied one of those and look at the mucosa, what you see are increased numbers of eosinophils, these red staining cells throughout the esophageal mucosa. And again, there aren't supposed to be any eosinophils in the esophageal mucosa normally. And sometimes you can see collections of these cells, these eosinophils, that form microabscesses. So that's the histopathological features, and we've talked a little bit about the clinical features. Now, because of the inflammation in the esophagus, these patients develop a number of different behaviors to help them cope better. So they tend to eat slower than other people. They're usually the last one finished at a meal. They fill up quicker than others. So they may be very hungry, but they only eat a few bites of foods, just enough to take away the hunger pain, and then they stop. They're picky eaters, and they'd rather eat softer foods or drink liquids than eat dense foods like steak or meats or other densely textured foods like breads, for example. And they tend to shy away from foods they have to swallow as a big firm bolus because, again, their esophagus is inflamed and it hurts or the food sticks. They like to use sauces on foods because it lubricates the food so they go down easier, and then they cut the food into small pieces and chew it up thoroughly and drink lots of liquids with meals, again, to make the food less dense so that they can swallow it. And the reason they do that in some of the patients is because they have strictures. You can see on this slide, this is a barium esophagram, this is the barium here, and you can see this area that's narrow. There's narrowing of the esophagus, a little stricture in this particular area. So what they're trying to do is make food less dense so they can get it through these areas easier. And sometimes they have difficulty, muscular difficulties, rather than true strictures. So if we look at the most recent consensus report in 2011, where they reviewed the literature and kind of updated our thoughts about eosinophilic esophagitis, they developed diagnostic guidelines and said that eosinophilic esophagitis is a clinical pathological disease defined by symptoms of esophageal dysfunction that we talked about right when we started, that there were findings on the esophageal biopsy specimens where you had more than 15 eosinophils per high-power field, that the disease was isolated to the esophagus, so you don't see increased numbers of eosinophils in other areas of the gut in eosinophilic esophagitis, and that other causes of esophageal eosinophilia have been excluded, like reflux disease, for example. And then, as you can see, part of the diagnostic guidelines is that patients respond to dietary exclusion, removing food allergens that might be driving disease, the use of topical corticosteroids, or both. So that's, again, part of the diagnostic guideline, is that they would respond to change in diet if you remove the right food allergens. The question is how to figure out which ones are the right ones. And then it's diagnosed by taking in or taking all of the clinical and pathological information into consideration. So there's not one finding that's diagnostic by itself of eosinophilic esophagitis. It's the whole picture that makes the diagnosis. So what are the therapeutic goals? Well, the therapeutic goals are to alleviate symptoms, make it so that they can eat easier, that they can choose other foods to eat, normalize the esophageal tissue so they don't have inflammation of the lining of the esophagus, and prevent complications. And I put a question mark there because some patients go on to develop strictures, but not everyone does that. And right now, we can't tell in advance who's likely to go on to develop strictures. We know if there's a family history of other people in the family who have eosinophilic esophagitis that have gone on to stricture, that suggests that this particular patient might have a higher likelihood of doing the same, but right now we can't really tell who in the future is going to do it. So we treat patients, again, to alleviate symptoms, normalize esophageal tissue, and we hope that by doing so, we'll prevent other complications that can go along with this disease. So what about the dietary management? What's used? Well, we use elimination diets, and the rationale is that if you take away the food allergen or antigen that's driving the inflammatory process, then their symptoms should get better, and the inflammation in the lining of the esophagus should get better. And again, it makes sense. If you think about it, when you put a food in your mouth and chew it up, basically you're preparing a food allergen extract. And when you swallow, you're essentially layering that extract very effectively over the lining of the esophagus as it goes down into the stomach. Now again, if the lining of this esophagus is normal and healthy, very little allergen will penetrate into the tissue to cause any symptoms. But if you have irritation and inflammation in the lining of the esophagus, you may get some penetration of those food allergens or interaction of those food allergens with cells in the inflammatory process that can then play a role in continuing to drive the process. In addition, once the food reaches your stomach, once the food reaches your stomach and goes into the small intestine, as it digested and goes into the small intestine and is absorbed, it can come around through the bloodstream and also get back to the esophagus to cause symptoms there as well. So what are the types of elimination diets that are used? Well, we use elemental diets, and what that means is that the food is broken down into its smallest parts. So if we take proteins, proteins are made up of strings of amino acids. And there are no proteins in elemental diets. They're individual amino acids that are in the solution. And there are simple carbohydrates in the solution as well. And that's important because your immune system sees things by using receptors. And receptors are molecules that can grab 6 to 8 amino acids, for example, and recognize them, and that would stimulate the immune system. If they're only single amino acids, the receptor can't get a hold of anything to recognize it. So that's why elemental diets are not allergenic. They don't have proteins that the immune system can see and get a hold of and be activated by. And then there's the non-directed elimination diet. It's called a 6-food elimination diet. And basically some researchers said, well, you know what, we ought to take out the major food allergens. So we'll remove milk, egg, wheat, soy, peanuts, tree nuts, fish, and shellfish. That's more than 6 foods, but still it's called a 6-food elimination diet, and see if people get better with that. And the third type of elimination diet that's used is the tailored or directed elimination diet. And that's really based on the clinical history of reactions to foods and also allergy testing that's done, and we'll talk more about that. So how did we come to find that diet played a role? Well, this is one of the first papers to describe eosinophilic esophagitis, and they had 10 children who had reflux disease that did not respond to treatment, and when they biopsied them, they had 15 to 100 eosinophils per high-power field, and they placed them on an elemental formula, and their esophagus normalized. So up above you can see abnormal esophagus, and down below you can see the normal esophagus. So that was one of the first hints that food allergens might play a role in triggering this disease. There have been studies by others as well that have supported that. This is a study by Dr. Liakouris and his group. They had 381 children with eosinophilic esophagitis, most of whom had reflux that didn't respond to treatment, or they had food sticking in their throats. 6% of them had narrowing of the esophagus. All of them responded when they were treated by oral steroids. Half of them responded to treatment with topical fluticasone that was swallowed. but all of them developed symptoms when the steroids were stopped. And when they used diet restriction or amino acid-based formulas, elemental formulas, these were highly effective in inducing the remission and maintaining the remission, and only 2.4% of patients were unresponsive. Now again, this is a younger population, but what it suggests is that in a large number of these patients, foods tend to drive the inflammation. And in addition, in this study, the barium swallows normalized in 21 of 22 patients who had narrowing of the esophagus, like I showed you on the previous esophagram. So what about the different types of dietary management? Well, there's the elemental diet, again using the amino acid-based formula, as we talked about, and there's certain benefits. I mean, it's a complete removal of food antigens, so there aren't any food allergens in the elemental diet. It's very effective in the majority of children that it's been tested in, and we think it would be very effective in adults as well. A number of these patients improve within 7 to 10 days with symptom resolution. They feel much better. And if you took pieces of tissue from their esophagus, you'd find that within 4 to 5 weeks, that's normalized as well. If there's no improvement in a patient who's on an elemental formula, then it's unlikely that foods are the driving allergen in that situation. The difficulties of the elemental diet are that it's hard for people to live off of an elemental diet alone. Once you get beyond an infant or a toddler, it's because of taste issues, it's difficult for older children to ingest enough to meet their nutritional requirements. So some of these patients may need to take some of the formula, at least if they can't drink it all, by a nasogastric tube or even G-tube feedings in some situations. These formulas tend to be constipating, so you have to pay attention to that. They're expensive, and not all insurance companies cover them. In fact, a number of insurance companies don't, even with letters from physicians suggesting that it's important. And there are psychological factors in the sense that eating is such a social behavior, and it's difficult to receive all your nutrition through an elemental diet. So what about the 6-food elimination diet? Well, again, in that diet, you remove the 6 major allergenic foods: milk, egg, wheat, soy, peanuts, tree nuts, fish, and shellfish. And in a study by Dr. Kagawala and associates, there were 35 subjects, and 74% of them had documented improvement in both their clinical symptoms and when they looked at tissue from the esophagus. When they compared the 6-food elimination diet to the elemental diet alone, 26 out of 35 patients responded to the 6-food elimination diet, whereas 22 of 25 responded to the elemental diet. And again, elemental diet removes all food allergens, so it tends to be a little more effective than the 6-food elimination diet. But it's interesting that the 6-food elimination diet is a very effective treatment. So the benefits are that you don't have to have allergy testing. I mean, this is empiric removal of the major food allergens. It's been demonstrated in more than this study to be effective. It's not as exclusive as the elemental diet. In other words, you have other foods in your diet. And it's not as expensive, because elemental formulas can be very expensive. But the difficulty is that the 6 foods that are eliminated, and really more than that, are pervasive in the diet. So it's not all that simple of a diet to follow. So that takes us to the third type, and that's the directed or tailored elimination diets. And the idea here is that the cause of food can be identified by skin testing, allowing for an individualized approach to therapy. And we use several different means to try to identify foods. I think as we talk about this, it's important to know that any unpleasant reaction that occurs after food ingestion is an adverse reaction to a food. A food allergy is an immune-mediated reaction to a food. In other words, the immune system is involved in producing the reaction. And there are different mechanisms that can play a role. For example, IgE is the allergy antibody. So children who are or adults who are allergic to peanuts, they have an allergy antibody, IgE antibody, directed against peanut. And the reason that's important is these patients have a positive skin test. If you make IgE antibody to a food, you have a positive skin test to that food. But there are also non-IgE mediated mechanisms. In other words, mechanisms other than IgE are involved in producing symptoms. And the problem there is that skin tests are negative in patients who have this form of immune system response to foods. And if we look at eosinophilic esophagitis, it's a classical mixed IgE and non-IgE mediated disease. So positive skin tests will help you, but they may not give you the whole picture. And then it's important when you think about IgE-mediated food allergy to realize the difference between sensitization and clinical reactivity or true allergy. There are a number of people who have a positive skin test to a food but can eat that food without symptoms. And that's true in eosinophilic esophagitis as well. The skin testing helps us identify foods that might be a problem, but it doesn't tell us necessarily that they are a problem. And clinical reactivity, or true allergy, is when you combine the evidence of sensitization by skin test or blood test using IgE antibodies, looking for IgE antibodies directed against foods, plus symptoms with exposure. So how about skin testing? How do we do it? Well, we buy commercial extracts that are 1 to 10 or 1 to 20 weight to volume. You can also freshly prepare extracts to use, and then we apply those by prick skin testing. We wait 15 minutes and read the results, and you get a wheal, this bump here, surrounded by an area of redness. And people measure the longest diameter of the wheal and the perpendicular to that, and the longest diameter of the redness or erythema and the perpendicular to that, and that's usually what's recorded. So a skin test at 3 millimeters larger than the negative control is considered to be positive. That's by convention. The bigger the skin test, the more likely you are to react on exposure. But again, it's not, like I said before, there are some people that have a positive skin test but don't react on exposure. Now we're talking here about classical food allergy, not EoE. In EoE, eosinophilic esophagitis, we don't, I'll show you some data that kind of speaks to the positive predictive accuracy, but it's about the same or a little less actually. And the negative predictive accuracy, in other words, negative skin test, means you don't react to the food, is a little bit less than 95% in eosinophilic esophagitis. This is really speaking to a classical IgE-mediated food allergy. You can also, and I think this is an important aspect of the evaluation, is take a history of the fruits and vegetables a patient eats and other unusual things a patient might eat or a person might eat, and have them bring those in and make fresh extracts. So they put a small amount in a Ziploc freezer bag. You can add saline, crush it up, and take that solution and do a skin test. You can also do what's called a prick-to-prick, where you take the fruit, prick the fruit, and then prick the patient with the applicator and check for skin test response 15 minutes later. This is helpful particularly in evaluating fruits and vegetables because they auto-digest with time if you try to make an extract. So we have a number of patients who have a negative skin test to a commercial extract of a fruit or vegetable, but if you take the fresh vegetable and take it the way they eat it, if they eat it cooked, you have them bring it in cooked. If they eat it fresh, you have them bring it in fresh. And oftentimes when you skin test into that, it'll be positive even though the skin test of the commercial extract is negative. And then there's some foods that patients eat that we may not have extracts to, so that helps you have a way to check different foods where we don't have a commercial extract. But you have to remember that these extracts made in this fashion are not standardized. And in fact, a number of our commercial food extracts are not standardized either. And so people often, report that I went to one doctor and got these skin test results, I went to another and I got different skin test results, and the question is, why does that happen? So it happens because doctors may be using different skin test reagents. I may get mine from one company, someone gets theirs from another company, or they may be using fresh extracts. The test device that's used to prick the skin and introduce the allergen can vary. Sometimes the technician putting on the extract may press harder than someone else and actually cause a little irritation from pressing too hard. Placement makes a difference because skin tests are larger when they're placed on the back than they are on the forearm, for example. There can be patient factors. Some patients have pressure-sensitive skin, and when you stroke their skin, they get a little bump. So you need to understand if the patient has what we call dermatographism when you're doing skin testing, and that's why we put on a positive control that's histamine and a negative control that's salt water. You should have a positive response to the histamine, obviously. You should have a negative skin test at the site where saline is used. And then you need to read them in the right time frame. If you wait too long, you may miss the response. And then different methods of measuring results sometimes result in different findings. So the summary is, if you look at studies, you may find differences among the studies because of the reasons I just talked to you about. And also geographic region may make a difference because some people become allergic to foods not through ingestion of the food, but because they're exposed to a pollen. and proteins in the pollen may cross-react with allergens in a food. For example, patients who are ragweed allergic may develop oropharyngeal symptoms, itching in their mouth and throat after the ingestion of banana or the different melons. We do not use intradermal testing, injection of small amounts of allergen underneath the skin when evaluating patients with food allergies. And we often use freshly prepared extract in evaluating these patients. And the positive predictive accuracy is relatively low. The negative predictive accuracy is reasonable, but you have to be careful because it doesn't mean necessarily that the food absolutely does not cause a reaction. And a skin test size doesn't predict severity of reaction. It does predict likelihood of reaction. So the bigger the skin test, the more likely you are to react on exposure to that food. The other way to do this is to check the blood for allergen-specific IgE directed against a specific food. This has been done for classical IgE-mediated reactions to foods like the children who are allergic to milk or egg or peanut. This has not been done for eosinophilic gastrointestinal diseases. So the higher the number, the more likely it is to play a role, but we don't have cutoffs that says above a certain amount that food would definitely be involved. The point I want to make here again with this form of testing is that determination points predicting high likelihood of reaction have not been established for this disease like they have for some of the foods involved in classical food allergy. And then Atopy patch testing is another form that's used to try to identify foods that might play a role. And in that situation, there are aluminum chambers called thin chambers. A food extract is placed in the chamber and it's taped to the back. As you can see at different sites, this is one that's being read, but you place it in the fin chamber, tape it on the back, and then you remove the fin chamber at 48 hours. You read it 20 minutes after you've taken the tape off and remove the chamber, and then the final reading and most important reading is 24 hours later, so 72 hours after the food was placed. And then it's scored based upon the presence of bumps, papules, or vesicles, little blisters. And again, we do not have standardized extracts for use in eosinophilic esophagitis. But it's proposed as a way to help identify delayed reactions because, again, we don't have a great test to identify delayed reactions. And again, Dr. Spergel has written some excellent articles using targeted approach with both skin testing and patch testing. And in one of his first papers, he had 26 patients that had eosinophilic esophagitis, and they identified potential food allergens by skin testing and patch testing, and then had patients avoid those foods based on the results. And of the 26 patients, 18 had a complete resolution of symptoms, 6 improved partially, 2 were lost to follow-up, and the eosinophil counts improved from an average of about 55.8 to 8.4%. And the foods most commonly identified were milk and egg, and you'll find that in a number of these studies, the foods that are more commonly identified are the ones that are in the 6-food elimination diet. So their conclusions were that there was evidence for a mechanism being involved other than just the allergy antibody IgE. In a number of the patients, the symptoms got better after 2 weeks to a month on the elimination diet, and that the symptoms returned within minutes to days. I mean, it was individualized when they tried to add foods back to the diet. They talked about the fact that patch testing isn't standardized, and so we need to be careful in interpretation, and that they mentioned it's difficult to rule out the role of environmental allergens. We know that some patients get worse during the spring or fall if they're allergic to allergens that are in the air at that time. So their recommendation was that you remove foods based on skin testing and patch testing, and that after all the symptoms are gone, you can add foods back to see which foods cause symptoms, and if they don't get better, you might need to use an elemental formula and then introduce foods every 5 to 7 days. That was their suggestion at that point. If we look at the consensus report, the first one, they said, well, although promising results have been obtained in at least one center, that's Dr. Spergel's, the use of this test should be reserved until additional data clearly establishes its value. And so then the follow-up consensus report said, well, there is some variability. The negative predictive value, though, was pretty high, greater than 90%, except for milk. And milk is an interesting food because, again, you can have a negative patch and it can still play a role. So and then the other thing that was stated in that consensus report was that the positive predictive value is variable in children. So if we look at the benefits of directed or tailored elimination diets, it's individualized therapy. And that means that some of these patients may be able to leave foods in their diet that you would take out on a 6-food elimination diet, definitely on an elemental formula. And there's a potential improvement then on a diet that's less restrictive. But the difficulties are, reliability, commercial extracts versus fresh extracts, and the patch testing. Again, the extracts are not standardized, and you have to be careful in your interpretation of those results. You can wind up on a diet that's overly restricted, for example, and in the issue with milk, you could have a negative skin test and still milk might be playing a role. And also, it takes time to perform this testing, and it can be expensive. So in a comparison, this slide compares several different approaches. This is based on a study by Dr. Kagawala. The first one, this is the directed targeted diet based on Dr. Spergel's approach, and this is the elemental formula based on an article by Dr. Leah Coors. So you can see that improvement in patients histologically and clinically occurred in 74% who were on the 6-food elimination diet, 77% on the targeted diet, and 95% got better on the elemental diet. And if you looked at the number of eosinophils that were still in the esophagus, 13.6 in the group on the restricted, the 6-food elimination diet, 12.8 in the targeted diet, and 1.1 again on the elemental formula, because again you've removed all food allergens. That's why this is the most successful. So there have been other studies since these studies where the numbers may be a little bit different, but the findings are the same, that the elemental formula is the most effective in leading to symptom resolution and clearing up of the inflammation of the esophagus. But the problems are what we mentioned before, that oftentimes it's a difficult diet to follow, particularly for older children and adults. And the other two diets are relatively similar in the response to both the 6-food elimination diet and the targeted diet. The interesting thing is that in most of the studies that look at the targeted or directed elimination diets, the most common foods that are involved are the ones that are in the 6-food elimination diet, milk, egg, wheat, and soy in particular. And so the remainder of this talk if we talk about the dietary management, there's one other point I want to make, is that patients with eosinophilic esophagitis are at high risk for nutritional deficiencies because a number of them are relatively picky eaters to begin with, and a number of the children fail to thrive, and so when you first meet them, they're having difficulty. And so you want to be careful about placing them on overly restrictive diets, and they can have side effects from inappropriate monitoring of an elimination diet. So involving a dietitian who specializes in working with children who have food allergies and children who have eosinophilic esophagitis can be incredibly helpful and is highly recommended. And again, the adherence to the diet can be difficult and it can be costly because again you have to shop for these different foods, and the elemental formulas, for example, can be expensive. And then there's also an impact on quality of life because sometimes the diets are restrictive and you have to take that into consideration and monitor that. So I have 3 other articles that I'm not going to go through today, but they're comparing the different types of approaches to dietary management, and the points they make, although there's some finer points, are what we talked about in the last slide, where the elemental formula is the most effective and the 6-food elimination diet and the targeted formulas are both relatively similar in their effectiveness. And so any of those therapies is a reasonable approach, and it really depends on the individual patient and where they are and how they'd like to approach it in working with their care team. So with that, I'll close and we'll take questions. Okay, so one question here is, when avoiding soy, does that include highly refined soybean oil? Also, what about coconut? Well, we tend to, there's some things that are usually fine in eosinophilic esophagitis, and it's the protein that people react to. So the highly refined oils remove the protein from the oil, so there's almost no protein in those highly refined oils, so they're usually well tolerated. Soy lecithin is usually well tolerated as well, and that's important because, again, soy oil is in a lot of different foods, so that opens up the diet more for patients. And here's a question about patch testing and the size of the fin chamber. Does the size of the fin chamber make a difference with regard to whether the results of the patch test? So, sorry, does the size of the fin chamber make a difference in the results of the patch test? And actually, that's an excellent question. We tend to use the larger fin chambers that are 12 millimeters in diameter in patch testing in this situation rather than the smaller fin chambers, because you may get a negative result with smaller fin chambers. All right, here's another question that said, did I understand correctly that allergens in the blood can cause an EoE reaction? If so, does that mean that food trials can be done through a G-tube? And yes, you can have a reaction to food allergen in the blood. I think you do get more contact with the lining of the esophagus by ingesting the food, but but it has been shown that by putting food in a G-tube, for example, I mean, sometimes there's reflux as well, so that the food can reflux up into the esophagus and have direct contact and cause symptoms. But it can also, the food can be picked up in the bloodstream as it's digested, and allergens can be transported around. So if you were thinking about adding foods back into the diet and the patient had a G-tube, you could start by feeding foods through the G-tube and see if they tolerated them. Another question is, how about immunizations, any that are more a risk for someone with multiple food allergies? And that's a good question. Immunizations tend to be tolerated well by patients with food allergies. There are reactions that can occur with immunizations. The ones that we see tend to be related to the antibiotic that's in some immunizations called neomycin. Some patients have an allergic reaction to that. Gelatin is found in some immunizations, and there are patients who have reacted to the gelatins in immunizations, although those are rare. And then some immunizations contain egg-like protein. But the interesting thing is, for example, the MMR is reported to contain egg-like protein, but it's tolerated in patients who are egg allergic. And the flu vaccine has a small amount of egg-like protein, but the vast majority of patients who are egg allergic tolerate that without any problem. And there has recently been some articles published that suggest that patients who are egg allergic can receive the standard flu shot that contains less than 1.2 micrograms of egg-like protein in it without any difficulty. And in our institution, we've been giving a significant number of children each year who are egg allergic to flu vaccine without any difficulty. So if you have any questions about that, I'd encourage you to talk that over with your allergist. But just because you're food allergic doesn't mean you can't receive vaccines. In some situations where the vaccine is required or very important, giving small doses and increasing the amount allows for the vaccine to be tolerated. Here's an interesting question. Is it possible to test for food allergy sensitization by using tissue culture from an individual patient biopsy and measuring increase in eosinophils or related metabolic precursors? It'd be great if we could have tissue cultures, take samples from esophageal biopsies and add food allergen and then look at release. The problem is that is too cumbersome and too expensive at this point. But that's an interesting question. And again, by the time you cultured out fibroblasts or whatever and had them grow, I mean, again, you wouldn't have the cells that you would expect to react in the right fashion. So what typically is the first step to managing EoE from a food perspective? If allergy testing yields no food allergies, would you remove the top 8? remove just one type of allergen and then rescope? Well, the point is there are several different approaches to this disease, and I think in where I work, we talk over with patients what they would like to do and how they would like to approach it, and we give them several different options, because each of the things you mentioned each of those approaches are viable. It depends on what the patient wants to do. So let's say we have a patient and you've taken the history and they can't tell you that there's a particular food that causes symptoms, and you skin test them and their skin tests are negative, and patch testing is negative as well. Then you could still remove the top 8. You could do the 6-food elimination diet that they talk about and see if you had a response there. Although for some patients, they might look at that and say, that's just too much, I can't do that right now. You know, some people are thinking about removing milk, soy, wheat, and egg. I mean, those tend to be the top 4 in a number of studies. There's some people might consider just removing milk initially to take a look and see if that made the difference, because milk is one of the most common foods involved. So it really, the treatment approach in that situation can be individualized based upon where the patient and their family is in treatment and what they think they can do at that point in time. The patient who wants to have the best chance of getting better after the initial diet might say, I'm going to opt for the 6-food elimination diet and take all those foods out of the diet and see how I do. There may be another patient who says, I just can't take all those foods out of my diet right now, or we may be worried about that because of the child's or person's nutrition, and opt to take one of those foods like milk out first and then see how things go. So here's a question: since symptoms return when taken off the steroids, should you try all elimination diet options before introducing steroids? And I think that's a personal choice. And I think, again, that's something that's decided upon after talking through all the options and talking things over with the care providers. We see some patients, for example, I see some adolescent patients who, when you approach them about a very strict elimination diet, feel like that's almost worse than the disease process itself. And in that situation, while they're kind of getting their head around having eosinophilic esophagitis, or if they're in a difficult situation, I have some patients that are going off to college, for them, the best option at that time might be to try topical steroids and get them some relief and help them feel better and give them a chance to think about their illness and how they would like to approach it over time. And we have a number of patients who may start with topical swallowed steroids because of other things in their life that make it difficult to follow an elimination diet, and then come back later to say, okay, now's a good point in my life, I can pay more attention to my diet, I'd like to look and see if dietary elimination makes a difference. And I think that's certainly a reasonable approach. This is a disorder that lasts a long period of time. It doesn't tend to go away spontaneously in a short period of time. And so there may be different phases of a person's life who has this where they find that one option works better for them than another. And I think it's important to be able to tailor treatment to the patient's individual situation. Here's someone, the question is, if you only have the blood testing at the time of elimination, is there any value in those results? Again, if we're talking about allergen-specific IgE antibodies to foods, sometimes they can help you in making a choice. I like to see the results of skin testing as well, because sometimes the immunocap, or measuring the specific IgE antibody in the blood, is negative when the skin test is positive. But I wouldn't say that the value of blood testing at the time of elimination of foods is useless. I mean, there is some value in the results you get with allergen-specific IgE levels. I mean, if they're really high, you'd probably want to withhold that food from the diet. The problem is we don't have exact numbers to say if the value is above a certain level, that food should definitely be removed from the diet. Here's another question. When a patient changes treatment approaches from elemental diet to steroids, how are foods reintroduced? And again, there are different approaches to this. In some institutions or some places where that treat eosinophilic esophagitis, foods are added to the diet for variable periods of time. Some people use 5 to 7 days, as I mentioned to you in the that was in Dr. Spergel's article that we talked about. Some people like to wait longer than that to make sure. I mean, there's some places where a food will be introduced for 3 weeks to a month, and then another endoscopy will be performed to make sure that there's been no change. In other situations, we have some patients where we're trying to reintroduce foods to their diet a little quicker, and we may add several foods to their diet and see how they do. If they do well, we may not perform an endoscopy at that point and add some other foods. If they have a problem, we may back up and add one food at a time. So again, it's not like there's only one approach. You know, again, a number of centers are going to add one food at a time and wait anywhere from a week to a couple of weeks to some even longer, and then, you know, add in another food and see how things go. But there's not just one way that's the only way to reintroduce foods. Is gelatin safe for those with beef or pork allergy? Well, there are patients who are beef or pork allergic who tolerate gelatin, but there's some who don't. So this is where we get back to skin testing to gelatin. And again, in patients who have beef or pork allergy, you know, since sometimes those gelatins can be in vaccines, you know, we may skin test to gelatin or skin test to the vaccine in that situation to see if they tolerate it. Is long-term steroid use an option in lieu of an elimination diet, specifically for a 10-year-old? Well, the swallowed topical steroids that are used in treatment of eosinophilic esophagitis tend to be very effective forms of treatment. And the good news is they're not well absorbed, and so there's not much systemic exposure to the amount of steroid that they're ingesting. And so, you know, the use of these agents tends to be well tolerated. So we do have some younger children, I mean 10 years of age, for example, where an elimination diet would be very, very difficult for them. And we do have patients that have been on swallowed steroids for longer periods of time. The interesting thing is that you would predict, you know, based on our interactions with asthmatics patients, that we would see a large amount of thrush or a yeast infection in the mouth or throat as a result of the use of swallowed topical steroids. And the truth is that we see much, much less than we would expect. It's a very small percentage that goes on to develop thrush. So for the most part, we think the use of these topical steroids in patients who choose that option is very well tolerated. We don't see these patients having difficulty with growth or having excessive weight gain. I mean, we're looking for most of them to gain weight anyway because we're trying to get them better so they can gain weight. So I think it is a viable option, but we are looking, we have a study now looking more at long-term effects. So we're looking at patients who've been on topical swallowed steroids for longer than 4 months, and we're checking a morning cortisol level to make sure their adrenal gland is not suppressed by the dose they're getting. And then there's some other tests we're going to do so that we can answer that question better in a year in our population of patients with eosinophilic esophagitis who are treated with topical steroids, swallowed. Here's a question. What about natural sugars like honey, sugarcane, molasses? Are these essentially protein-free? And honey is interesting because it can be contaminated with pollen, and it depends upon where the bees collect their pollen. So we do see patients with positive skin tests to honey, and sometimes they have a larger positive skin test to one type than another, and we think that relates to, again, the pollen that's collected and the patient's sensitivity. And it's rare to see reactions to sugarcane and molasses, but if these are being used in large amounts, you know, in our patients, if they're using molasses a lot, sometimes we will skin test the patient just to make us and the patient feel better that their skin test is negative. If a patient has a clean scope, in other words, there isn't any inflammation in the lining of the esophagus, but still has EoE-like symptoms, how could you do a food trial? Or should you even do a food trial? And that's a great question. Again, it is true that there is oftentimes a disconnect between symptoms and findings on endoscopy. We have some patients who are symptom-free, but when you biopsy them, they still have significant inflammation. And we have other patients who are where the inflammation has cleared, but they still have symptoms. What we try to do is give them a little bit more time to see if their symptoms resolve, if they were just recently treated and have become and have responded. But in some patients where they still have symptoms but would like to reintroduce foods and that becomes important for nutritional adequacy, we might proceed with the trial and see if symptoms worsen. Obviously in that situation, at some point after you introduced a few foods, you'd have to look again and make sure you hadn't caused inflammation to return. Does it matter if food proteins are heated and damaged after exposed to a certain temperature as in baking and grilling? Do people tolerate them? Again, another good question. So in patients with classical IgE-mediated food allergies, we know that about 70% of the patients who are allergic to milk or egg tolerate milk or egg in baked goods that's been heated at 350 degrees for 30 minutes. And the reason they tolerate it is because, again, there are certain, I mentioned to you that the IgE molecule has a site on it, has a receptor site that can recognize 6 to 8 amino acids in a row, or 6 to 8 amino acids. If those 6 to 8 amino acids, say there are 3 from one part of the protein and the protein's folded, and there are another 3 that are close, so that's what the patient is allergic to, that's called a conformational epitope. When you heat that protein up, it changes the three-dimensional structure and denatures that allergen. So the patient who's allergic to a conformational epitope can often tolerate the food if it's cooked for a long period of time. If the amino acids that make up the epitope are sequential, in other words, right in a row on the protein, oftentimes those aren't denatured by heating. So when we do challenges in children who are egg allergic and they react, the children who react are the ones who are allergic to 6 amino acids in a row. And the ones who tolerate are the ones who are allergic to the conformational epitopes. We wonder if that could also be useful in treating patients with eosinophilic esophagitis. So are there certain patients who might tolerate that? And I think there's an article that's going to be coming out saying that some of the patients who are milk allergic might tolerate milk in baked goods that's baked at 350 degrees for 30 minutes. So that's an important point because, again, when you start adding foods back to the diet, sometimes if you add the food in its raw state, it may be more allergenic than if you cook it. And so we have patients where, for example, they don't tolerate fresh apples, and if you skin test them to extract from a fresh apple, they have a big positive skin test. But if you give them applesauce that's cooked, or if you skin test them to cooked applesauce, their skin test is negative, and some can tolerate that without a problem. So again, these are different ways that you can sometimes add foods to the diet that patients would like and not put them at risk. How effective is dietary management for adult patients? Again, it can be very effective. The thought process is that it may not help as many people as it does for children because, again, foods are a major cause of eosinophilic esophagitis in children. The thought process is that in adults, some have other factors like environmental allergens that drive their disease as well. There can also be genetic factors that play a role. So you'll find articles that say it's less, dietary management is less effective in adults. But it would be interesting to look at a larger number of adults with not only skin testing to commercial food extracts, but also thorough testing with fresh extracts of foods that are made from foods that are in the form that the patient eats them, so cooked or uncooked, etc., to see if that would be helpful. And again, the 6-food elimination diet can also be effective in adults as well. Here's a question about a 6-year-old boy who was diagnosed at 2 with eosinophilic esophagitis. Is the 6-food elimination diet just going to be a way of life? Is that the long-term solution? Well, again, usually we do what we need to do to control inflammation and help patients to feel better. And sometimes that involves elimination diet, sometimes that involves topical steroids, sometimes that involves both. Once the patient is better, we don't just sit at that spot. Usually we start to taper the swallowed topical steroid and see if the elimination diet we have is working. And in patients who are on elimination diets, we're often trying to figure out, okay, what food could we potentially get back into the diet? Because we have a number of patients who want to know, do I really need to be avoiding milk? And so they pick a time where if they have symptoms, it doesn't disrupt their life as much. And then we may try to add that food back into the diet and see if they can tolerate it. And we have had patients where we initially took a large number of foods out of the diet, but over time, with adding foods back in, we got the majority of foods back into the diet. So even on the 6-food elimination diet, it might be that your child can tolerate peanut or tree nuts or egg or some of those. It may be that milk is the only one that drives it, or it could be that wheat is the only one that drives it. And the way to do that is, after everything is under control, pick a time and then try to add the food back in and see if it's tolerated or not. If prick tests are not effective, then why aren't we seeing more patch testing? And again, I'm not trying to make the point that prick tests, skin tests, are not effective. I think they can be very helpful. I mean, we have a number of patients where they've helped us select a diet. And to me, it doesn't make sense to have a patient with eosinophilic esophagitis eating a food regularly that they have a large positive skin test. It's just we wish they were, more black and white than they are. I think you have to interpret the information correctly. But I think they do bring something important to the table because they help you identify foods to which the patient has made allergen-specific IgE. And again, they're not standardized. You have to be careful. But patch testing isn't standardized either, and patch testing has issues as well. So the point I'd like to make is I think both skin testing and patch testing are helpful adjuncts to learn more about sensitization of the patients and which foods, what the diet might look like. You just, have to realize that it's not black and white, that there's some interpretation there. As a child grows into adulthood, do EoE triggers change? Are there typically more or less triggers? In young children, over time, they may outgrow some of their food allergies. A number of children who are allergic to milk or egg outgrow that allergy over time. And a lot of them who are wheat allergic may outgrow that allergy over time as well, or soy. The thing that we see in some patients is they become sensitized as they get older to seasonal allergens. And they may start to have symptoms when they eat foods that cross-react with seasonal allergens. As I mentioned earlier, we have some patients who become sensitized to ragweed, and when they eat bananas or melons, because there are proteins in ragweed that cross-react with melons and banana, they may have oropharyngeal symptoms and itching of their throat, and those foods can start to play a role. There are other pollens that have interactions with other foods. Birch pollen cross-reacts with apple and hazelnut. And again, there are a list of these foods that we usually think of as oral allergy syndrome or pollen food allergy syndrome. So we see some patients as they get older get pollen sensitized. There are other foods that start to bother them that didn't bother them previously. There's some other patients where they just develop other food allergen sensitizations because they have allergic inflammation of their esophagus, and now some of the foods they're exposed to are presented to the immune system through that area that's inflamed. And so we can see patients who develop food allergies. We see other patients who, again, as they get older, and if their eosinophilic esophagitis is well controlled, outgrow some of their food allergies too. So, any advances in finding a better way to count EOs in the esophagus in lieu of endoscopies? And that's an important question. We'd certainly all like to be able to reduce the number of endoscopies that are necessary. And there are, you know, some techniques that are being explored. There's the there's a string test where a patient swallows a string and leaves it down for a period of time. And when you pull the string out, you can look at the part that was in the esophagus and then assay it for different eosinophil components. And there have been some preliminary studies that look at the amount of components on the string and compare that to the number of eosinophils that are seen on biopsy, and there is a correlation, but it's not ready for clinical use yet. We hope that within the next few years it will be, and I'm sure there are others that are working on other ways to try to help us reduce the number of endoscopies that are necessary.
Thank you, Dr. Atkins, so much for taking time out of your day to be here with us and answer these questions.
Thanks for having me, and I have to say I really appreciate everyone who came and the great questions they asked, so thanks for letting me participate.